Well, thank you to the organizers for inviting me to speak. This is a really special and unique opportunity to talk directly to you all and with you all. And thank you for coming. It's an exciting time, and I think you see that. And there aren't many forums like this. This is really special. So thank you. Dr. Pearl sort of talked a bit about sort of what's so exciting now. And I'm going to talk a bit about sort of how do we get there. And it turns out it's actually a relatively long story. Despite the sort of recent excitement, this has been work that's been going on for more than a century. And so in a few different stories I'll sort of walk through today, I wanted to talk about sort of how did we ever know that the immune system mattered in cancer? How do we figure that out? How do we get to this point where we're now treating patients with therapies that have the potential to substantially increase their life, both in terms of their quality of life and their length of life? And along the way, how did we learn about how to harness the immune system for the treatment of cancer? This is a sense of a timeline that at the bottom of the slide here, and you can see that this is indeed a long story. And each of these will represent sort of a few different stories that we'll go through. But I think the sort of linear timeline gives sort of a false sense that this was sort of one step along the next, that it was the sort of the next thing that came naturally from the first thing. And in fact, this story has lots of successes and a few setbacks, and along the way has led to what has been a tremendous rise in the use of immunotherapies for the treatment of cancer. Before sort of starting about how do we get here, I thought it would be useful to sort of set the stage of where are we here and why does this matter? And this is the same sort of spider plot that Dr. Porterfield showed. But what's tremendous is this was a melanoma patients with melanoma that were treated with a combination of nivolumab and ipilimumab. And what you can see is that although a few patients had a growth of their tumor, which is indicated by an increase in their tumor, many of these patients had a substantial decrease in their tumor size, and that lasted for a long time. This was so substantial that it had to make up a new number in order to quantify just how many people benefited. This 80% regression in the tumor volume was never been seen before, and so this was a totally new metric that had to be made up in order to encapsulate the true benefit of these sorts of therapies. To put a more personal face on this was a picture of a woman, a 96-year-old woman with head and neck cancer, who was treated with a PD-L1 therapy, and this was presented by Neil Siegel at ASCO this past year. And you can see that before beginning therapy, she had this large tumor at the bottom of her, this is her jaw. And just 1 month after beginning therapy, the tumor had shrunk tremendously. And Dr. Siegel had coined this the smile sign of immunotherapy, and I think that's probably the right way to describe it. But these are the patients that we're seeing. Some of you may be them as well, and this is why we're talking about this at all. It turns out that this sort of story started with a very similar picture, actually. This is a gentleman, a 31-year-old gentleman, who was treated at what ultimately became Memorial Hospital in New York by a surgeon named, well, actually he wasn't treated by this particular surgeon, but William Coley was a surgeon at what became Memorial Hospital, and he was a surgeon treating sarcoma patients. And there was one patient in particular whom he had to amputate, and unfortunately that young patient ultimately died, but it pushed him to ask about whether there was alternative ways of trying to treat these cancers. And he looked through both the literature and the case reports of this hospital and found a few cases, including this gentleman here, who had been infected with a type of infection which we now know to be streptococcus. And during the infection and for 7 years thereafter, this tumor that was at the base of his skull there had regressed. It happened during the infection, and this picture was taken 7 years afterwards. He found this gentleman who was taken care of by a Dr. Bull, and you can see that that tumor had not come back and remained scarred down. And this showed that there's something about the response to infection that was able to also treat cancer. He then published a series of 10 cases of patients that he had treated on his own, as well as what was a rather remarkable case series where he found all the cases in the literature, beginning with this case in 1868, of a patient that had developed this infection and had a regression of their tumor. he ultimately treated a small handful of patients, and over the course of his lifetime, many, many patients with this sort of infection, purposely giving them an infection to induce a fever and hopefully a regression of their cancer. Unfortunately, this medicine, to the extent that it was, also resulted sometimes in infection and death of the patient, which was at least one of the reasons why this medicine isn't what we use today, understandably. Dr. Coley also ran into what was, at the time, the most remarkable advance in cancer therapy, was the advent of radiation and the use of radiation to treat cancers. And as radiation took over, cancer immunotherapy took a back seat. But there are a few legacies of Dr. Coley, including being a founder of the concept of immunotherapy's use in cancer. And one of them is his daughter, Helen Coley, who ultimately founded Cancer Research Institute, which is an organization that funds and organizes cancer immunotherapy research. She found his papers in the 1930s and ultimately was his champion through the 1940s and 50s and started CRI. The reason I mention her here is just to emphasize how important single people, even non-physician, non-scientist people, can be as advocates, as important champions of this work. And she's a prime example, as are all of you. And the other reason is that because of their particular focus on immunotherapies, there is a series of webinars about immunotherapies and cancer research that I think are sort of mimicking some of the videos that have been made by Dr. West and Grace, but that's a useful resource potentially. Another one of the legacies of Dr. Coley and Coley's toxin is the idea that you can use infections to try and treat cancers. And this is one of the very few, if not only, types of infections that we use to treat cancers. And this is what's called BCG. It's a type of tuberculosis bacterium, and is actually now routinely used to treat bladder cancers. The concept is that you inject just small bits of this sorts of bacteria into the bladder of patients that have bladder cancers, and that in this, you can see in this initial publication in 1970s, that of these 7 patients, 6 of the 7 had this is a few years later, had regression of their bladder cancers, and many of them don't come back. And so this is just one example of how infections can actually be used to try and treat cancers. I think another legacy, and one that we'll start to hear more and more about in the coming years, is the use of oncolytic viruses to treat cancers. And the same concept applies, is how can you use an actual infection in order to induce an effective immune response? This was just reported at ASCO in 2014 as a type of herpes virus called TVEC, in which you inject bits of the virus into individual components of this melanoma, though not every area is injected. And you can see several months later that all the melanoma is gone. This is a sort of mouse experiment that shows the same thing, but I think is part of what's exciting in the next wave of immunotherapies for cancer. This is a mouse with a small bit of melanoma on its backside, and another one on the other side. And in this one side here, it's injected with a virus called Newcastle disease virus. And additionally, there's an injection of ipilimumab to the mouse. And you can see in this table that if you give nothing to the mouse, neither the tumors, neither on the right or the left, go away. But if you give the virus, this area goes away in about half of them, and this area goes away in about a quarter of them. And this area goes away in about a quarter of them. If you give just ipilimumab alone, you get similar results. But if you give both the virus and ipilimumab, you get reduction in this area as well as the other area that's not injected with the virus, demonstrating that there's an ability of circulating parts of the immune system to induce immune response if it can be taught to do so. One of the questions in the early 1900s was, what are those components? What are the pieces of a cancer that allow it to be recognized by by the immune system? And much of this gets its start from Paul Ehrlich, who is a German scientist, and he developed a multitude of things, but one of them was the whole field of histopathology, the ability to stain specific parts of cancer and to see what the individual components were. And using various dyes, he demonstrated that individual components of each cell with various dyes made different colors. And it seemed that the different physical or chemical properties of a dye bound differently to different parts of the cell. And that there were individual ways in which a dye and a part of the cell linked together. And this was part of what was termed sort of a lock and key idea, that there was individual dyes or other parts that were circulating, individual parts of the cell that could link with one another. And this ultimately led to the idea, what was called the side chain theory of immunity, which was that there were individual parts of a cell that could bind to parts of toxins. In the same way that there were toxins and infections, there were individual parts on the cell that bound to those toxins. And if the cell was able to survive that given infection, those side chains were able to help prevent that infection in the future. He termed the coin receptor, which we use all the time now. And this idea, which was mostly a postulate at the time, was remarkably accurate, and has led to the development or the identification of what are called antibodies. These are circulating receptors in your own body that recognize specific things called antigens. And this is the lock and key. This is the antibody with the antigen. And the idea of how you use this for treatment was, he had termed a magic bullet, which was that if you could identify the specific antigens on the surface of cells that make them different, you could try and treat just that cell. If you could find what makes a melanoma cell, how it looks on its surface, the way you stain it with a dye, you could use an antibody that targets just that antigen to try and treat it. And it turns out that that's remarkably true. And the use of what are now called monoclonal antibodies to treat cancers has been a tremendous wave since the 1970s. You've heard all these medicines, nivolumab, pembrolizumab, rituximab, et cetera. You hear at the end that term mAb, and that denotes any monoclonal antibody. All of these medicines that we're using now are monoclonal antibodies because they target a specific antigen, whether that's PD-1 or PD-L1. But that's where all of this got started. He postulated then that if it weren't for the concept of cancers having individual antigens and the immune system ever existing, that there would be many more cancers. But that because of this circulating system, the ability to identify cancers and eliminate them by the immune system, we're here, and that we're not ravaged by cancers. The question then, and starting into the 1950s, was, can an immune system really recognize individual components of cancer? Where does that evidence come from? And this experiment, I think, will look very similar to the Newcastle disease experiments that I showed just before, where that if you take a mouse and put a bit of tumor on its hindside, allow the mouse to live with the tumor, to allow the tumor and its own immune system to circulate with that tumor, but then take the tumor away, either by taking it out by surgery or to ligating it, and then give a bit of the tumor back again, the mouse is able to regress it on its own. And this is a tremendous response, but indicative of this initial priming, this initial exposure to a cancer is what ultimately led to its regression later. You could imagine that this is very similar to the way that we use vaccines now. This is why you all get flu vaccines, which you should this year, is that you take a small piece of that, bits of the antigen of the flu virus, and you expose your own body to it, so that once your body sees that infection in the future, it's able to regress it before it matters. It's not that it protects you from ever seeing the virus, but it allows your immune system to respond to it if you do. And so then the question is, what are the bits of cancer that make it recognizable to the immune system? Why is the cancer foreign in the immune system, in the eyes of the immune system? And in that context, it's useful to take a step back to talk about sort of what makes a cancer a cancer. And what makes a cancer is the serial accumulation of mutations. When we typically think about mutations, we think about the genes that you develop from your parents that you might give on to your children. But mutations in the context of cancer only happen in the cancer. These generally are not things that you pass along to your family. But they are part of what makes a cancer recognizable to the immune system because it's a change in what would otherwise be a normal cell. And so what makes a cancer is the ability to go from what are normal things to the development of one mutation that maybe allows this one cell to be a bit bigger. But that mutation also creates a new antigen. The next step may be that mutation, a second mutation occurs that allows it to grow more than it should. And a third mutation that allows it to grow still further. And a fourth mutation that allows it to spread. And this is how cancer develops, is this serial accumulation of mutations that give it qualities that allow it to grow and spread when it shouldn't. But it also allows the immune system to start to see this cancer as a foreign thing. And so this led to the sort of theory of immune surveillance. And this was postulated by McFarland Burnett and Lewis Thomas in the 1950s. And I'll sort of read to you what he wrote because it's remarkably on target despite being 60 plus years old. And he wrote that it's by no means inconceivable that small accumulations of tumor cells may develop and because of their possession of new antigenic potentials provoke an effective immunologic reaction with regression of the tumor and no clinical hint of existence. The idea that we may have cancer cells popping up all the time, but that we never know that they existed because the immune system is able to delete them before they matter. That's a remarkable weapon and one that we want to harness now to reestablish an immune response to cancer. But the idea then was that what was sought was some protective mechanism of the body, our own body's immune system, to try and treat this cancer by finding things that are different from the self patterns. What makes a cancer cell look different than your own cell that allows the immune system to recognize it separately. So that's where the idea of immune surveillance came from. In the 1970s was a bit of a step back, a setback at least, in terms of whether the immune system really did matter in cancer. And Osias Stutman was also a clinician and scientist at Sloan Kettering, and he performed what would be sort of the expected experiment, which was that if you had a mouse or a human that had no immune system, if indeed the immune system mattered in cancer, you should expect that there'd be more cancers if you don't have an immune system. If immune surveillance is right, then if you lack the immune system, you should develop more cancers. And so in the 1970s, he used what are called nude mouse, and these are mice that lack a thymus gland. And as a result of lacking that thymus gland, they're unable to develop mature T cells, the mature parts of the immune system. And yet he found that when he used these nude mice or normal mice and exposed them to a carcinogen called methylclanthrin, that the development of tumors happened about the same percent in either scenario. And they happen at about the same time, too. So in this setting of nude mice that are exposed to a carcinogen, tumors happen no more frequently and happen no more quickly in the absence of an immune system. And so that shut down the concept that the immune system mattered in cancer for a little while, though in the meantime, many people were toiling with the idea of whether this was indeed true. And this led to the resurgence of the concept of immunotherapy, immune surveillance, and so forth in through the 1970s, 1980s, and now, when it was identified that nude mice actually don't lack an entire immune system, and that there are multiple components of the immune system that are still intact, that weren't appreciated at the time of Stutman's experiments. And some of those included cytokines like interferon, as well as other components, actual parts of T cells, and in addition, the entire parts of the entire innate immune system that Dr. Pardell talked about. And this is part of where these experiments were repeated. That again, if you give a tumor one that's lacking the ability to see interferon and expose it to methylclanthrin again, that these tumors actually do develop more frequently and more quickly than you'd expect. And one extrapolation of this has been the use of interferon in the treatment of melanomas as well as other types of leukemias, in which patients who get interferon after surgery, they're less likely to get the melanoma to come back. And I'm not advocating for interferon. I know that's a controversial subject, but it at least demonstrated the ability of specific components of the immune system to actually durably regress cancers. And then the major turning point in 2001 was a remarkable paper by Bob Schreiber's group at WashU, in which they showed that they actually were able to specify individual components of the immune system that if you lost it, you were more likely to develop these cancers. And this was a gene called RAG2 that actually, more specifically than nude mice, actually inhibits the ability of the immune system to make T cells. And if you repeat the same experiment that Stutman did, that if you expose them to a carcinogen and then see what happens over time, that those that are lacking an immune system actually develop many more tumors. And so this reestablished, I think, firmly the idea that the immune system really, truly did matter in cancer. Not only did the lack of the immune system allow for cancers to develop, but he also showed that the immune system can be used to durably regress these cancers. And that if you treat mice with a type of cancer in which their immune system's intact, and you transfer that cancer into another mouse in which the immune system's intact, all of those cancers grow. It's the same cancer, it's just in a new mouse and it grows. But if you grow a cancer in a mouse that doesn't have an immune system, in which that cancer is able to grow on its own without the ability of the immune system to interact with it, and then transfer it into a mouse which has an immune system that's now able to interact with the cancer in an effective way, you can see that some of these cancers do grow, but half of them don't. Half of them are rejected by the new environment in which they're exposed to the immune-competent space, where an immune system is able to get rid of these cancers once they're reimplanted. And so Bob Schreiber and Lloyd Old and Mark Smith at Stanford have presented the idea of the 3 E's of immunoediting. And finally, after more than a century of work, we sort of has a conceptual paradigm for how the immune system can interact with cancers. And it starts with the idea that a cancer starts from normal tissue, but that once it is exposed to various mutations or other things that make it a cancer, it changes in some way. Those changes are associated with the ability to show tumor antigens on the surface. That's part of what makes the immune system recognize it as foreign. And that if there's an effective immune response, that cancer can be eliminated. That's the first E of the immune system, is the elimination of cancers before we even know that they're there. But sometimes those cancers may not be eliminated and they exist in an equilibrium phase in which the immune system and the cancer are coexisting in ways that may change the cancer or may change the immune system, but the cancer itself is static. It's possible that many of us have this sort of stage as well. It's ongoing, but because the immune system is keeping an equilibrium, we're okay. But ultimately, a cancer that we find in the clinic are ones that are growing, and these are the ones that are spreading and causing patient symptoms. And that's the evidence that the cancer can escape the immune response to cancer. And it's the ability to try and go backwards, which is what we're trying to do, is how do we move from escape back to equilibrium, or elimination if possible. And so to just sort of briefly jump ahead to the idea of checkpoint inhibitors, which are, I think, the most promising part of today, is the idea of that accelerator and brake that Dr. Perdol talked about. And along this axis here is how well T cells proliferate. And you can see in the backside here, T cells proliferate extraordinarily well. And this is where the accelerator is all the way on. But up here, in this corner, you have none of the accelerator and all of the brake, CTLA-4. And you can see the T cells are inhibited. And this is this counterbalancing of the accelerator and the brake. This is the initial work from James Allison in 1990s, that showed that there were individual molecules that played with this seesaw and were able potentially to be a therapeutic target. In experiments, it showed actually rather remarkably that if you gave something that blocks CTLA-4, these cancers don't develop, they stay flat. And if you give the tumor again, they don't grow. Well, if you'd never given the CTLA-4, the ipilimumab, the cancers grow in both scenarios. But then to jump ahead to sort of where we are now, this is what we're doing. This is a patient of mine who was treated with the Merck anti-PD-1 drug, and this is a tumor that's just along the chest and right up against her aorta. And then more than a year later, after getting this therapy continuously since, the tumor is essentially gone. This is the result of more than a century's worth of work, but this is the promise. This is what's so important. And to show not just one patient, but several is these therapies in which we showed Dr. Walchuk's paper before, in which they had to make a new metric in order to show just how much these tumors regressed. And this is lung cancer patients that were treated with the Merck PD-1 therapy, and you see that about 58% of the patients that are in this bar had some regression of their tumor, and some remarkably. But it's also important to remember that we still have this part of the curve and these parts of the curve to try and do better. And that's part of what I think you'll hear about today and moving forward. But this is a remarkable start. So it's been a long journey, but I think one that is tremendously satisfying with a few setbacks, but I think the tail is irrevocably forward, starting from this picture and ending with this picture. It's not the end, though. And I think that's an important part to keep in mind. That this is a long history, and this is not where we stop. Jed Walchuk has said that this is the beginning of the end. I'm sorry, the end of the beginning, and I think that's right. This is the end of the beginning. The beginning was that century, and now we're entering into a new phase, of which we know that this can work, and how do we make it work better is a tremendous opportunity. But we do need to do better. And so with that, I'll thank you all for coming, and that's the story.